Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. We've had a lot of calls and really emails about the issue of behavioral health. You know, it's come up so quickly in our society today. You know, they talk about people shooting people, the Montgomery Stoneman Douglas issues and like issues around the country. But it has to do with, as I believe, behavioral issues. And I said, let's get some qualified people here. And I think we've got some of the very best in the nation sitting in front of us. So let me introduce Dr. Jared Gaines. He's a board-certified psychiatrist and the chief medical officer of the Fort Lauderdale Behavioral Health Center. Welcome, doctor.
Thank you.
Good.
Thanks for having me.
And looks like the big boss is here. He's the chief executive officer of Fort Lauderdale Behavioral Health, Manny Llano.
Glad to be here.
Tell me about the behavioral center. I know it's a multifaceted part of a very large corporation. So give me some idea as to what the Fort Lauderdale Behavioral Center is, well, where it's located.
Fort Lauderdale Behavioral Health Center is located in Oakland Park. It's on Dixie Highway between Commercial and Cypress Creek.
Right.
We are a 182-bed hospital, level 1, which means that we're totally locked and secured, with multiple segments of level of services providing from children to adolescents to geriatrics, with both behavioral health and substance abuse services that are provided both in an outpatient and an inpatient basis.
We spoke a bit before the show. It's a very large corporate entity that has international presence. So why don't you let the folks know?
Yeah, Universal Health Services is the parent company. It owns over 350 hospitals in the U.S. We're in 37 states in the U.S. We also have a large amount of healthcare facilities in England, over 90 hospitals in England. We're a public traded company, Fortune 500 company. Over the last few years, the last 8 years, we've been nominated as the most admired company to work for. So we're very glad and very happy to have such a support as our parent company.
Well, thank you, Dr. Gaines.
Yes.
The area of behavioral health is so broad. But let's give the folks some ideas of what actually, not the care level of what occurs, but who are the patients that end up in your facility in Oakland Park?
Specifically the ones that come to the facility, as Manny had mentioned, inpatient and outpatient. They're coming with predominantly a diagnosis overwhelmingly of depression and or substance abuse. We also have children, a lot of times with depression, suicidal thoughts, suicidal tendencies or behavior, aggressive behaviors, people with addiction that really want to be able to obtain and maintain sobriety and improvement. We also do electroconvulsive therapy for severe depressive cases and transcranial magnetic stimulation also for severe depressive cases. So those are people that would be coming to the facility.
You know, you just mentioned something.
The TMS?
Yes, the
Yes.
TMS. That's rather new to
Yes.
it's rather new relative to the acceptance of what I would call the general medical community.
That's fair to say.
That's a very interesting thing. Just touch on that and tell us what it does.
Sure. TMS stands for transcranial magnetic stimulation.
Right.
The idea being that stimulating certain areas of the brain is how we treat depression. Medications help with that. ECT also helps with that by causing a seizure. Transcranial magnetic stimulation targets specifically the part of the brain called the dorsolateral prefrontal cortex, where they've been able to narrow where mood is regulated, specifically depression. So we're able to use an MRI strength magnet to stimulate that area of the brain, no anesthesia, no memory loss, and we see very good results with it. for training?
You know, a lot of, and I don't want to get into any divisive commentary relative to medical care, but you know, a lot of folks think of the difference between a psychiatrist and a clinical psychologist, for example.
Okay.
The main difference, I mean, just to be blunt about it, is the fact that the psychiatrist has the ability to write prescriptions, either this way or still on a pad. So help me, again, get to that issue.
So then, excellent. On the deeper point, my training also included significant background in psychotherapy. Cognitive behavioral therapy is able to identify people that are reality-based, but distorting it, seeing it through a lens that actually isn't the case due to their depression. I don't, you know, we'll hear a lot of times that people would refer to you as a cliche, oh, you're a prescription, but no, that's not. That's never who I have been. That's not who I am. That's not why I'm the chief medical officer. That's not why I'm excited to work where I work and help develop the programs that I can. I want to do it properly. We use evidence bases, and even to the point of what we were talking about before, a lot of the changes that have happened in the mental health field, which then became behavioral health, just because of the stigma of the term, comes from ignorance. It's hard to import motives onto people. Do they not care? It's not knowing that seems to be the larger issue when it comes to knowing how to get help or how to improve your life.
And if I can add something,
Sure.
I mean, you know, the TMS is a very non-threatening procedure.
Right.
You're sitting in a very similar to a dentist chair with kind of like a headband that basically provides the therapy, and the results are amazing. You know, people are getting well. People are getting off of medications. Depression. People feel a lot less depressed or no depression at all, and it's a very non-threatening procedure that anybody can go 15, 20 minutes in the dentist chair, like a dentist chair, and get treated.
Well, it's we'll go back to you again, Dr. Gaines.
Yeah, but to your larger point, is it a Band-Aid? Basically, is it something that might scratch the surface without getting at the core issue? There's nobody with self-respect that wouldn't be recommending and or engaging and requiring. I require patients to do cognitive therapy. I do it myself on the unit. I'm one of the people who help writing the programs that patients are following. During TMS, you can actually speak with patients and do brief cognitive therapy while they're actually getting TMS. So the idea being, where is guilt coming from? Where's the hopelessness coming from? People that you mentioned that were shell-shocked from their experiences in war. Even if you understand broadly that topic, you'd have to be able to speak to them to know where they're coming from and understand their pain and suffering for them to be able to trust and transition that to you. So a therapeutic relationship is the cornerstone for improvement, whether we're talking about ECT, medicines, TMS as well, and also would give you an exit ramp for people to actually get better. So to that, no, a prescription pad or a TMS machine or an ECT machine in isolation, even though it was never like what you saw in the movies back in the 1940s, none of those things by themselves would work. It takes an entire healing process. So no, but to your point, you're right. And I would get comments like that all the time. Oh, you're the first doctor to talk to me. But where I was trained, I didn't know that would be a rarity. I don't know how to do it properly without. It's difficult enough to treat, even with using all the tools that we can bring to bear, not just one by itself. But yes, to its point, TMS does also add improvement in outcomes for depression symptoms. It is not a replacement, nor should it be a replacement for cognitive behavioral therapy, and when done properly is used in conjunction with.
Again, we have a lot of magnificent psychiatric care in our community in South Florida, really in the state of Florida. Where you were trained, I would assume that, I know you went to the University of Florida, I know that there's a lot of...
well, I can say Nova didn't have a medical school when I went to UF, so there.
No, I will beg to differ with you. We've always had our College of Osteopathic Medicine, which started in 1985, actually graduated first class.
Okay.
But that's beside the point. The bottom line is that in today's world, in fact, even in the accrediting world, DOs and MDs are accredited by the same body.
Yes.
Mr. Llano.
Right.
Tell me about the. I know the facility. That's the old Northridge Hospital.
Correct.
Right. I know the facility. I'm sure that it was lying dormant for quite a while.
12 years.
Yeah, and it's very easily easily accessible. I know the area very well. Anybody who knows whose children go to Pinecrest, it's within that region.
Yes, sir.
Within like 5 minutes of that area. And I just wonder, are you a regional, do you get regional patients? Or tell me more about the population that seeks out your services.
We really are Dade, Broward, Palm Beach,
Right.
you know, but we do get clients from, we have a contract with the VA.
Right.
Where we help with substance abuse and rehab for VA patients. So we typically might get out of network or out of the area clients. We're typically, though, a Dade, Broward, Palm Beach facility.
Well, the reason I ask you that is because you just hit on something, and I want you to be aware of it. I'm going to do a little information for both of you. We've been honored by the Governor DeSantis' administration to be selected to be a veterans care center for health issues, and of course the PTA. We have a very large veteran population here. A couple of thousand veterans are matriculating with us within our whole system, because we're just not here in Fort Lauderdale, Davie. We have ventures in Jacksonville and Fort Myers and Orlando, Tampa, Clearwater area, like I said, Miami, and Puerto Rico. So what I'm saying to you is that we've been chosen not only by them, but also the federal government has given us a number of grants. As large an organization as you are, and knowing that you have VA contracts, we do a lot of work with the VA and a lot of research with the VA. So just make me aware.
We're also starting a first responder unit in the first quarter of 2020, which are going to be working with PTSD. We're going to be working with substance abuse clients, and really try to focus on those folks that instead of having to go out of network, go out of the state for these services, that we can provide those services with both fire rescue, police, and fire, and ambulance services. So we definitely are trying to be trying to grow our services to be able to see and fit that need.
Dr. Gaines,
Yes,
you brought up an issue about suicide. We did a couple of programs because there's been a lot of communication with us, and again, brought about by the trauma events of these mass shootings, particularly Marguerite Stoneman Douglas and the Orlando shooting and things of that nature. And a lot of people point to whether it be the pro-Second Amendment versus the, I don't want to say anti, but it's the elements, it's the shading of the Second Amendment. The utilization of firearms to kill people. But they all point to the mental health issues. And I can tell you that we had experts sitting right here. It's very stark relative to the number of males and females that commit suicide. And it would be very, very interesting to hear your comments about the issue of suicide, because here at an education institution, we take that very, very seriously. We provide mental health services by contract to protect our students. We provide mental health services for our employees and our academics to help them get through some of the crises that occur. Talk to that suicide issue for a while.
Sure. Well, I guess to stay focused on the part that you're talking about, part of my residency at the University of Florida, we rotated through the student mental health clinic,
Right.
Helping to run group therapy, and very often suicidal ideations, thoughts, hopelessness. It would vary from people worrying they're not going to graduate and letting down their parents, to previous sexual trauma, to substance abuse. So it was the same litany of diagnoses that adults experience, just in younger folks that weren't able to or didn't feel that they deserved the ability to feel better or have anyone to speak to. As far as men and women, the statistical data would indicate that women are far more likely to attempt, but men are far more likely to complete suicide, usually because they'll engage in much more violent, aggressive means. And if you look at prison populations, overwhelmingly more male. The most aggressive of individuals would be male, leading to completed suicide versus suicide attempts. We see similar patterns with utilization of healthcare for depression is overwhelmingly more female to male in asking for help and approaching help, as opposed to not approaching help, as well as substance abuse higher in the male population compared to female population, and length of time that they're using before achieving help, if they're going to achieve it. So the majority of otherwise deaths by opiates don't appear to be suicide attempts, they're overdoses on the opiates. So there is a comorbidity of substance abuse impairing people's judgment, impulsivity, and then carrying out suicide attempts for people that want to kill themselves. But the majority of deaths by drug abuse are consequences of the drug abuse and not via death that someone would sign up for.
Yeah.
Yeah, I was just reading. I was reading an article from Pew. It was a research paper from Pew Center. Pew Center, and they were talking about the increases of mortality. I mean, the death crisis that we're having all of a sudden in the United States of America, where states like New Hampshire, Kentucky, etc. I'm just naming a couple of them. The deaths due to opioid overdose is dramatic, and it's causing deaths when I don't know whether the people recognize what's happening. Is it? And again, that's why I ask you: is it tied together, laced together at some level with
prescription medications? But I don't know how, of course it's attached to mental health. I don't know how it could not be. There isn't going to be somebody that has a drug addiction that isn't also suffering from that use with mental health, or whether it's being used to, as they'll refer to, self-medicate. But language gives us away. Let's be careful. This is poison. So there is no indication for poison as a health product. People will do it because they're craving the feeling that they get from it, or the lack of pain that it's bringing them, even though it's not solving the problem that they need help for in the first place. And it might be their ability to access care. It might be their lack of willingness to access care. A lot of times it appears to be lack of access.
Or education.
And lack of knowledge on how to actually move forward with it, or thinking, life, I deserve this. I don't deserve to feel better, and depression playing a strong comorbid role in it. I think it'd be a mistake to take a 30,000-foot view and assume that everybody is following the exact same path. What would be the influences? Substance abuse is not going to improve anybody's life. If you had depression before, it's going to make it a whole lot worse. It could be brought on by it all by itself. And if the argument otherwise was, well, nothing's been able to help me, I promise you the heroin's not going to help you either. So you see comorbid use, and sometimes needing to have ownership and admittance to the substance problem so they can get help for it without the stigma that goes with that, as well as simultaneously help for the depression that otherwise for them might carry a stigma, and provide education so that they're aware of how common it is, and also that it is in fact treatable. And then to speak to something else that you mentioned, what we're trying to focus on is, one would be abundance of care, but it's abundance of efficacy. I have to make sure that we're always humble in looking at our product. Are we actually getting people better? Are we doing things properly? Are we following recommendations? Do we see outcomes that are what we would expect from this intervention? If you had multiple sites available for care but not running programs properly, you wouldn't see an improvement in care just because you have more centers. It's the quality of those centers that matters very much, and then the availability of quality. Do we see suicide correlated with substance abuse? And we use the word crisis. I mean, one of the jokes is death's been happening as long as humans have been around. Death from opiates, that should never happen. It does happen, and it is happening in an increasing amount. There's a lot of data out there about fentanyl and its addictive properties being reintroduced with heroin, and more availability of substances. Then there's the other question, well, is this because what we're doing is we're giving them antidepressants or more medicines that makes them become dependent on medicines? If you've thought of every pill as being an equivalent, then that would be the same as me saying a Flintstone vitamin, if you're taking every day, would increase the likelihood. It might be. It just depends on if we're using antidepressants properly for what it's supposed to do to help relieve depressive symptoms. It doesn't replace cognitive therapy. And we should always be helping people obtain and maintain sobriety in all circumstances, with or without depression, and also trying to use as little additional chemicals as possible.
And one of the things, adding to what Dr. Gaines was saying, as it relates to awareness and education, we spend a lot of resources with our staff to be able to go out to the schools where we educate students, educate teachers, and trust counselors and counselors at the school to be aware of symptoms that are happening within their school environment that can give us the opportunity to help the kids prior to having a suicide, prior to having an incident. So we also spend a lot of resources with our therapists and our physicians as well, doing community, service ideas of being able to introduce folks to, what happens when you take drugs, the addictions and things like that. So education and being aware of the outcomes before something tragic happens is part of what we try to do.
Do I understand, Mr. Llano, that you've been in communication with our school boards, both in Dade, Broward, and Palm Beach County, relative to the availability of your services?
Absolutely, we do that all the time. We're very involved in the shooting of the school last year. Yep, last year, where we provided therapists and we provided counselors, including physicians, at no cost to the community to be able to help. And we do that with ongoing education, and also with the police. We help Broward County with identifying triggers that could happen with police when they do pick up clients on the street, where the best low level of care is, and where the next area of transfer to be able to get the care that they need to, accordingly.
Well, to be candid, looking up the background of the corporation that you're affiliated with, I noticed that their presentation has always been the humanity of the community.
We feel we are a community partner, so our hospital is there to serve the community, and we're definitely would be willing to work with Nova in partnership to be able to continue to create awareness and provide services. I
want to thank you both for being here. Congratulations on creating a great service for our community. Again, you're at, tell us where you're located again?
We are on Dixie between Commercial and Cypress Creek.
And there's a telephone number which we will get from you?
Yes.
Okay, it'll be up on the screen. Okay. And Dr. Gaines, you're in a very valuable area of medical knowledge that is needed by our community. Everybody's pointing to mental health services. They might be blaming a lot of actions on the mental health problems, but I really think that if we make them more aware of the services that are available, less blame will be pointed at, and more help will come to you as a professional to support what you do.
And agree with Manny, the education, the opportunity to educate helps. I'm born in Broward County, so the fact that I'm back home trying to help make a difference here just means a lot to me.
Born in Broward County. Where?
Broward General Hospital. I grew up in Plantation, went to school at the public school across the
There you
street.
Okay, you went to the Nova Public School.
Nova Public.
Right,
Yes.
right. We just discussed that before. Well, thank you both again. We appreciate you being here and spending time with us. Mental health issues are very difficult to explain in a 30-minute program. Dr. Gaines, thank you very, very much. You were trained well, and we appreciate you coming back home.
Thank you for having me on your
Thank you
show.
very, very much. Folks, if you have any questions or comments, and I'm sure there'll be a lot of comments, there's a telephone number and an address right here. You can just communicate with us. Remember, I always tell you, take good care of yourself. And I always tell you, you got to tell your doctors. You know, whether you have a cold or whether you have pain or whether you have mental health issues that you don't realize you have or otherwise, you've got to tell them what's bothering you. This program is called Dateline Health. We come to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see ya.